Hi, my name is Stacy Pruitt, and I am going to discuss medically non-compliant patients who specifically have diabetes. There, obviously, anybody who has a medical complexity of any kind can have a non-compliant patient in it. But for this poster, I'm going to specifically discuss diabetic patients. The background here, patients can be considered medically non-compliant for several different reasons. One of those reasons can be that they just choose not to take their medications. Another reason can be that they just generally cannot afford their medications, want to see a provider, which is one of the, that's what I'm going to cover mostly in this poster, is the patients who are unable to afford their medications. So they are quote unquote medically non-compliant, but they are, it's basically because they cannot afford. It's not a choice. It's something that's handed to them. Even those at high risk of serious complication often resist following treatment regimen. Some of these patients, of course, are your diabetic population, and their insulin and insulin supplies. They need insulin to survive, but choose to underdose to save money. So even though they know that they are high risk of a serious complication, they still choose to feed their family this month instead of buying their insulin. So they're going to save their insulin by giving themselves less insulin. And they just try to keep their numbers just low enough to survive, essentially. Being diagnosed as a diabetic is a financial burden. My question here for my PCOT question is, my population is obviously the diabetic patients who are non-compliant. My intervention would be to secure their ability to get their medication. My compare and contrast question would be the risk of death in patients who can take their medication versus patients who cannot. Outcome would be for all diabetic patients to be able to take their medication as prescribed. Time frame, when all of these interventions and everything starts to take action, the time frame would be within the next 6 months to begin to see more compliance. Aims of the study: to keep patients out of the hospital because of missed medication. These patients are medically complex. They are going to end up in the hospital from time to time for whatever reason, but one of those reasons should not be because they're underdosing or not taking their oral diabetic medication. It should be for something else if they are going to end up in the hospital. Prevent the patient from becoming sicker due to other comorbidities because they cannot keep their numbers good with their insulin. So if they're underdosing and they're not taking their medication and their hemoglobin A1C is skyrocketing, they might be at risk for stroke or heart attack, or they may be choosing not to take other medications because they are able to take their insulin. So if they have hypertension, that's obviously going to get worse, put them at risk for stroke and other potentially life-threatening illnesses. So it's important that we not only get the patient to be able to take their diabetes medication, but they need to be able to take all of their medications. If they have other things that are going on, if they are a seizure patient, they need to take their medication to prevent seizures. If they have heart failure, they need to be able to take their heart failure medications. All of those are very high risk diseases, and if you're not able to take your medication for all of them, then you're going to end up in the hospital for one or all of them as well. So another hopeful outcome would be the save patients' lives by helping them have access to their medications as prescribed and go to the doctor as necessary. My stakeholders for this are The patient obviously is a stakeholder because it's their body, their life, their treatment plan. The patient's family wants them to be around. They're a stakeholder because they want the patient to take the medication, be able to take the medication correctly, so that they can keep their blood glucose and everything under wraps, so that they can live longer and prevent any comorbidity issues and ending up in the hospital and ending up sicker because of it. The primary care provider is a stakeholder because they're essentially dosing and prescribing the patient doses of medications. They don't even know how they're taking it. So most patients are not going to go to their primary care provider and be like, hey, so I didn't dose myself appropriately this month. That's why my A1C is high, because I couldn't afford to. Generally, they're just going to go in and the doctor's going to change their medication, and they're going to walk out and still not take the medication as prescribed. So the primary care provider's changing the prescription blind without even knowing how the patient is actually taking the medication. And that goes for everything. Urgent care and emergency care providers to prevent patients from using their offices essentially as a primary care because they can't afford to be seen anywhere else. Private insurance and government insurance is a stakeholder because if patients are not taking their medication as prescribed and they end up in the hospital, it's a lot more expensive for the insurance company as well as the patient, when maybe something could have been prevented by going to the office. Pharmacies are a stakeholder because they kind of hold the reins when it comes to the cost factor of these medications. If you look at my table, actually, I have some information specifically about different medications and how much they cost per pharmacy. So if you look at, I'm going to look at Lipitor specifically because it seems to be, let's see, Lipitor for a 30-day prescription at 20 milligrams at Costco costs $17, and at CVS costs $150. That's huge. That's a lot of, how can it range so widely? That's crazy. I know that all of these pharmacies make money in other places, so Costco may not make their money in their pharmacy, but how can we have a range that large? There should be a consistency in order to, so that these patients shouldn't have to shop around to be able to find the lowest price on each of their medications. Proposed interventions would be to use our role as a community health nurse to educate the at-risk population and the resources that are available to them. This can be helping them with discount medication cards, telling them where they can be seen by a provider for less, or helping them sign up for government assistance when they qualify. Education is going to be huge with these patients. Most of them just don't know what they can and cannot do when it comes to their health and their diagnosis. There needs to be more access to income-based clinics, doctors and nurse practitioners donating their time to help their community. This can be all the providers in the area donating maybe just a half a day or a day to one clinic and offering their services at a discount. There also needs to be a cap on prescription medications. This is for the pharmacies as well as the drug companies. There shouldn't be such a wide range from the drug companies as well. You should be able to provide a lower cost for these medications. I mean, it's life or death. So I know there are some states that are starting to cap certain medications so that people can get their medication at a cheaper price. or more affordable price. My expected results would be patients to be able to have the access that they need to get the medications that they need to survive. It's as simple as that. Patients always having access to a provider, whether they have the insurance or the means to pay. Patients not having to choose between paying their mortgage or getting their insulin filled each month. Patients having access to getting their necessary labs drawn so that they can continue to stay healthy. Patients not having to use the emergency room as a primary care provider because they don't have insurance. A reduction in hospital admissions because of having the ability to manage at home. And let's see here. So there is potential implications. Well, one of the anticipated conclusions would be to make the patient more aware of the risks that they are facing by being medically non-compliant and encourage them to seek assistance in helping pay for their medication and their office visits when needed. Potential implications would be people abusing the system. When there is discount or free items, people obviously think that they're entitled to it whether they are or not. So they take away from the people who actually cannot afford things. Another implication would be providers and drug companies not making enough money so that they give pushback. So providers not wanting to donate their time because it's a day of profit that they could be missing out in their clinic. They don't want to donate their time to another clinic. And drug companies, obviously, because it's their income, it's their bottom dollar if they lower their cost factors. Thank you for listening to my presentation.